Hello, and welcome to our live broadcast. Today we'll be highlighting Providence St. Joseph's Health annual report to our communities and our community health initiatives. I'm Dora Barilla, our Group Vice President for Community Health Investment at Providence. Joining me today in this live event, I have Dana Codron, our Regional Director for Community Health Investment in Northern California, and Martha Shanahan, our Leader for Community Health Investment in Humboldt County, located in Northern California. We are pleased to share our annual report showcasing our partnerships and commitments to the health of our communities. This report highlights how we give back and invest in vital conditions addressing health inequities. Our latest report focuses on our efforts over the past year, and we will also share today with you how we're building on those foundational investments to address the emerging needs over the past few months. The information provided during this event is for informational purposes only. If you have any medical questions, please reach out to your primary care or healthcare professional. So let's begin. Good morning, Dana and Martha.
Good morning.
Tell us a little bit about yourself and your roles within Providence.
Sure. Well, as Dora mentioned, my name is Dana Codron, and I am the Regional Director for Community Health Investment, also known as Community Benefit, in Northern California for Providence St. Joseph Health. My background originally is in nursing. That was a long time ago, working in the walls of the hospital, probably over 35 years ago, but always with the same organization with the commitment to serving those most vulnerable in our communities. And my passion and calling drew me into home health and then later into community and public health, where we are right now.
Yeah, and so my name is Martha Shanahan, and my role is as manager for community health investment for our two ministries in Humboldt County. So that's St. Joseph Hospital in Eureka and Redwood Memorial Hospital in Fortuna. And I've worked for Providence St. Joseph Health for about 8 years in this role. And prior to that, I have about a 15-year experience working in public health. I started my career in Washington State in the Seattle area, working for the public health department in Seattle and also for the University of Washington, primarily in the realms of public health nutrition. But in my role in Humboldt County, I get to provide support to community health investment programs that are working directly with vulnerable populations in our community, and also work to foster partnerships to help to correct some of the health inequities that we see in our community. It's wonderful to be here with you today.
Wonderful. Thank you, Dana and Martha. We're so glad that you were able to join us and able to share some of the great work over this past year. Dana, can you share a little bit how Northern California chose the focus areas in 2019, and maybe describe to our listeners what the Community Health Needs Assessment is and how we use it to invest in our communities?
Absolutely, Dora. So our Community Health Needs Assessment, also known as a CHNA, is a comprehensive assessment of the communities where we serve. And it's conducted every 3 years. And in fact, 2020 is a CHNA year for us. So we're in the midst of a needs assessment as we speak. And we use evidence-based framework, including sophisticated data analysis that allows us, for example, GIS mapping at the block group level for indicators related to health and social determinants of health. It's a very data-driven process, but also at the same time, it's deeply rooted in our mission. And we see it as really a sacred process, integral to the legacy and heritage of our founding sisters to serve the poor and vulnerable. So just briefly, our approach involves data from a variety of methods and sources. We have primary and secondary data that we collect and analyze, and Martha's going to go into the details of that. But we also analyze internal data around utilization. So we're looking at those avoidable emergency room visits and other prevention quality indicators. So for example, do we have a high number of emergency room visits related to diabetes or asthma? And if we see that in our local communities, then we can dig deeper into evaluating the root cause of that problem and perhaps plan some community level or upstream response and prevention efforts. Then that becomes part of our strategic plan to address these needs. We are able to pull mapping and demographics down to the block group level by ethnicity and age groups, by housing burden, block group, publicly available geocoded data. We use certain platforms that can pull any of 500 patient attributes and filter, for example, by population of interest. So demographics are filtered by behavioral health conditions, chronic conditions, and social needs such as housing or SNAP benefits. So we have a fabulous analytical process at our fingertips, but we also are careful in leaning into our community to really listening to what it is they are seeing that the needs are.
Oh, thank you, Dana. It's just always so affirming to hear, that the community health needs assessment is that sacred process, really grounded in our heritage and using our advanced analytics with just really listening to our communities. So thank you for sharing a little bit of the overview of that. Now, Martha, Dana talked a little bit about community level data. Can you talk how is that driving our decisions, and how do we ensure that we're including the voices of our most vulnerable populations?
Yeah, well, it's pretty remarkable, the sophistication of the data analytics that we have today, and it's also really important to remember that we balance that with listening to the voices of the people that we serve. And so, how do we do both? The community level data that we look at, and another way that that's typically described is population health level data. So instead of looking at one person's individual health outcomes, we're looking at groups of people, and so that can be an entire county, Napa County, Sonoma County, Humboldt County, and as Dana mentioned, we can drill down to a census tract level or a zip code level, so we can really see groups that are significant within our community to see what is affecting their health. And when we're talking about health, we're talking about a broad definition of health. It's not just about the absence of morbidity or mortality, but it's also all those social determinants of health, things like education, access to jobs, stable housing. And so those are some of the community level indicators that we look at. In the current needs assessment that Dana mentioned that we're doing, for example, we're looking at life expectancy at birth as an indicator for overall health. We're looking at educational attainment, so high school graduation rates. And we also are looking at the percentage of households that are at or below 200% of the federal poverty level, because we know that the presence of poverty is directly correlated with health outcomes. And so then we can take all that information and we can put it on a map, and we can see areas that pop up of higher needs within our counties, so we have more information about how we can intervene. Another important community level indicator is housing cost burden. Typically, people should pay 30% of their income towards rent or mortgage, so they have enough funds left over to pay for other things that you need: food, utilities, transportation, and maybe even be able to set a little money aside for savings. But we know in our service areas and a lot of our communities, 50-60% of the population is paying more than 50% of their monthly income towards rent. And that doesn't leave very much money left over for the other things that you need to stay healthy. We also look at indicators like from our schools, what are free and reduced price lunch enrollments like, and how many people are enrolled in the CalFresh program in the state of California. So, really all these things kind of give us a community level snapshot of the health in our service areas. But in addition to that, we really want to stay in touch with the people that we're serving and hear directly from people who have unmet health needs to find out what they're experiencing. So in all of our service areas in Northern California, we all have programs that directly serve people with unmet health needs. And we're in constant communication with folks in our community to really understand and to listen to what their day-to-day experience is like. And when things like a pandemic happen, we're able to know pretty quickly what the needs are. And so we're able to work with partners and respond right away.
Yeah, that's pretty exciting. Thank you, Martha, for really seeing how public health data has evolved over the years and how we can use that data to really drive our action is just really exciting to see. And we're so glad that you're able to have that level of analytics. Now, Dana, Martha talked a lot about the unmet needs of our vulnerable populations. Can you share a little bit how St. Joseph Health in Northern California hopes to address each one of those?
Sure, Dora. So across our region, with our current needs assessment, we've identified a few priorities that we're looking at. These are our priority needs that we established 3 years ago. And one is homelessness and housing instability or stability. The other one is mental health and substance use disorder. And then another one is access to care, not just healthcare, but access to benefits, access to resources and basic needs. One that rose to the top, particularly in Humboldt, was food security. So those are the areas that we have worked on over the past 3 years. And part of our strategy is understanding that hospitals can't do this alone. We need to engage with our community partners, and especially in areas where we don't have that subject matter expertise, such as housing, although Providence does have a housing division that has been fabulous at assisting us in these efforts. So we've established strong relationships with our community partners, and this is really critical. We leverage our resources to meet needs in a number of ways, and Martha touched on them, but one way is to provide conditioned donations to our nonprofit community partners. And this is when people think of community benefit, often what jumps to their mind is, oh, we make grants or contributions to the communities, but these are not willy-nilly grants into our communities. These are very strategic, and they're restricted specifically to meet an identified need in our communities. And they allow us to leverage our dollars and our resources to increase capacity in existing services, for example, increase capacity for mental health services or substance use services. It also can be used to seed new services that we need within the region. One example is launching respite programs, or what we call recuperative care or respite programs across our region for patients that are homeless in a hospital and discharging, and really do not need to stay in hospital, but are a little bit too vulnerable to discharge back to their prior living situation, which could be on the street or even in a shelter where they have to be outside the shelter during the daytime. So we have invested in what we call respite programs across our region in Sonoma and Napa County. Those are partnerships primarily with Catholic Charities, and in Humboldt County with private foundations and organizations that provide the same services. So we have invested our donations strategically to meet an identified need. Another way is, as Martha mentioned, is to provide services directly, and we do that across our region. We have a number of programs that deploy registered nurses, social workers, community health workers, promotors, dentists, behavioral health. We have addiction counselors. So it really varies in community to community, local to the identified needs. One program that I'll pull to the surface, because it is across our region and it has tremendous impact across our ministries, is a program called the Care Network. And this consists of teams of nurses, social workers, and community health workers that provide complex community-based care management. So these are persons who are often homeless or are unstably housed. They often have significant mental health and addiction issues, or multiple chronic conditions compounded by really significant socioeconomic issues. So intensive care and complex care is what we call this. And we helped these individuals to engage in medical care, secure their basic needs such as food and shelter. We assist them to apply and complete applications to receive benefits that include income as well as food and shelter. And we really are able to change the healthcare and quality of life trajectory for those we serve. And that we see an improvement in health indicators, we see an improvement in well-being and reported quality of life, and we see an overall reduction in emergency room visits and hospitalizations after enrollment in our programs. So this is really at the heart of our mission. It addresses all of the priorities that I mentioned above, and it also reduces the healthcare burden associated with avoidable utilization for these really high-risk populations. And lastly, we also have a long track record of pooling in grant funding and contracts that then we infuse back into our communities to help bridge gaps and meet needs. And so we're fortunate to have grant funding support from the Wellbeing Trust, from our St. Joseph Health's Community Partnership Fund, just to name a few. We also have contracts with Managed Medicaid and County Public Health, whole person care for some of the services that we deliver in our communities.
Yeah, that sounds like you've built long-time trusted community partnerships, Dana, that you're able to make those impacts. So thank you for sharing. Now, Martha, you and Dana both talked a little bit about Upstream. Could you share a little bit with our listeners what that means and how you're able to address, some immediate needs while also addressing some prevention for the long run?
Yeah, good question, Dora. In the public health world, the phrase upstream interventions has become quite popular. And there's a story that we tell in public health, or a parable about a river. So it goes something like this. There's two people who decide to go fishing in a river one day. And as they're fishing, they see someone floating in the river, floating downriver, struggling to keep their head above water. And so the two people respond to this person right away to try to jump in the river, prevent them from drowning, pull them safely to shore. So they're able to do that. But before they're able to return to their activity of fishing, here comes another person floating downriver, struggling, trying not to drown. So they immediately turn their attention to save that person and rescue that person. Yet here comes another person and another person. And so people hear their cries for help, and more people rush to come help and pull people out of the river to safety and to prevent them from drowning. And while all this is going on, there's a bystander that decides to walk upriver to try to find out why people are falling in the river in the first place. And so that's really what we mean by upstream interventions. It's trying to ask the question of, why are we experiencing these poor health outcomes in our communities? And what's the root cause? And can we move upstream? Can we go see why people are falling in the river in the first place and try to prevent that from happening, so we aren't faced with a crisis situation where there's too many people in the river and we don't have enough resources or capacity to save them all? And so that's really when we turn our attention to primary prevention. And primary prevention is really about keeping people healthy in the first place and preventing poor health outcomes and preventing disease. Because we know if that can happen, then we create the conditions in our communities where everyone can live a healthy life and everyone can thrive. But really what we think about at Providence St. Joseph Health and in community health investment is, how do we do both at the same time? Mm-hmm. Because we know that there are people in our communities right now who are suffering, who are in that river and drowning, mm-hmm. and we really are called to respond. We need to respond. But at the same time, we know that if we don't try to prevent the reasons that people are suffering, that we're going to continue to be in the same situation over and over again of just crisis intervention and trying to save people from drowning. So how do we do both at the same time? One example of how we've done that in Humboldt County is in the realm of addiction. We know that we have high rates of addiction in Humboldt County, as do many communities across California and across our nation with the opioid epidemic. And we've invested heavily in a treatment and recovery center called Waterfront Recovery Services. We know that people are suffering. We know that people want help with their addictions, whether it's alcohol or drugs. And often they're told they have to wait for a bed to open up or for funding to become available. So we've invested with Waterfront Recovery Services to try to increase capacity for addiction treatment and recovery in Humboldt. At the same time, we know we have to ask, what are the root causes of those addictions? Why are people suffering in the first place? And often when we ask why enough times, it leads back to some sort of trauma. And primarily early childhood trauma is often common. And so we know that we need to invest dollars and resources in trying to support children, especially in those first years of life and around the perinatal period, around pregnancy. So what that looks like, that looks like supporting parents who are raising young children so they can raise healthy kids and have the resources and tools that they need. It's supporting early childhood education in that kind of 0 to 5-year-old age group. So when kids come to school in kindergarten, they're ready to learn. And you're not trying to, at that point, correct things that happened in the first 5 years of life. And so really it's a balancing act, and we have to figure out ways and strategies to be able to respond to the immediate crisis at hand, but also focus on primary prevention and creating the conditions in our communities where everyone can be healthy.
Yeah, thank you for sharing that. I think a lot of times we hear that term and that just really brings it to light, Martha, what we're doing. So let's, we've talked a lot about our investments for last year, and you bring us to June 2020. And I don't know about you guys, but it often feels like 2019 was a lifetime ago with all the changes that have happened in our communities. So Dana, as we, look at moving forward, and you guys clearly have known about the health inequities in our communities for a long time, and it's no surprise to any of you, and and us beginning to address it. So now we add COVID-19 and a lot of the civil unrest. How do we turn really a disruptive moment into a generative moment that really includes longer term solutions addressing many of the root causes that you're talking about, Martha, to make sure that we're really impacting our communities for the long haul?
Yes, such an important question, and something that we're in the midst of, as we all know right now. In light of COVID, our work to serve the poor and vulnerable has multiplied dramatically, because we are seeing an influx or a surge of people, waiting in infinite lines for food, unable to make rent. We have people who never thought that they would find themselves in these situations, experiencing a lack of basic needs. So this work is urgent at this point, and we have to act at the moment, but we also have to look at the long term, Dora, as you said. We've known for decades that health inequities exist. That public health mantra that your zip code is more predictive of your health than your genetic code. We know that people of color have shorter lifespans than with their white counterparts, in fact, by decades. And in our region, even, we see the Latinx population compromises anywhere from 55 to 75% of the COVID positive cases. So we have these health inequities across our nation and in our local communities as well. The pandemic has also catapulted care and processes that have been in the works for decades. It feels like we've been trying to launch telehealth for so long, and suddenly with the pandemic, the bureaucracy and barriers to telehealth were removed so that we could do it and do it quickly. We also house the homeless in shelters and provided protection and surveillance. It's an opportunity for the public and private sector working together to bridge gaps in the communities. We don't want to lose ground here. So we are working diligently to sustain and galvanize these silver linings, if you will, of the pandemic. One way that we do this really in our region is we're working very closely with our government relations team to sustain these gains. And this is another example of when it's good to be both big and small. We are part of one of the largest Catholic healthcare systems in the country, and yet in our individual communities, we are very small and leaning into our communities and our partners. And so in this way, we're working closely with local public policy as well as statewide to galvanize some of these systems and structures that promote social justice and health equity.
Thank you, Dana. That's really insightful in terms of, addressing the immediate need and really building towards the future, which is really going to be so key, that we all lean in to this moment in time in history. Now, Martha, can you share just a few of your favorite stories that highlight the difference that you're making in Northern California?
Yeah, I'd be happy to. There's so many great stories. Dana mentioned earlier the Care Network, and the story that comes to mind is from our Care Network team in Humboldt. And it kind of illustrates the way that they work. And, Dana said it's a team of a nurse, a social worker, and a community health worker that provide intensive community-based case management for people that are experiencing homelessness shortly after hospitalization. So this story is, and I'll use the name Johnny, but he's a fellow that was in his 50s, chronically homeless for about 20 years, had compounding health conditions that were deteriorating and getting worse with age, in addition to issues with substance use. So his story in 2016, he had about 15 visits to the emergency room. In 2017, that jumped to 39 visits to the emergency room, plus 9 hospitalizations. So you can kind of see how the health is declining. In 2018, there were, halfway through the year, there were 23 emergency room visits, and then a really pivotal stay in our intensive care unit at St. Joseph Hospital, the ICU. It was during that kind of pivotal stay at the ICU that our Care Network team intervened, and the nurse met with the patient and talked about different options, the potential of going to our respite program that we partner with Betty Chin on, and one of those beds that Dana had mentioned that are set aside for kind of extra recuperative care after a hospitalization. And this time Johnny took us up on it, and he was ready to engage. And so from that point on, our Care Network team worked with him to make it to the follow-up appointments and then eventually get connected to housing. And by May 2019, Johnny moved into his own apartment. And ever since, he's been stably housed. He's had 0 visits to the emergency room and 0 hospitalizations. And in addition to that, he's also been able to take care of get some treatment for some chronic health conditions that he was facing. He even had a knee replacement and got a full set of dentures, and is still stably housed to this day. So that's the type of story that, when the timing is right, when trust is built and developed, and when there are these support services in place and community partners working together, we can really take someone from a very kind of desperate situation full of despair and provide some hope for a healthy future.
Yeah, thank you for sharing that story. It makes it real. Those investments that we shared when we started, really bringing it down to that individual person. That's really what it's all about, is impacting our communities. We're just about at time, but just want to give you guys one last opportunity. Is there any other wisdom or just incredible work that you guys would like to share with our listeners today?
Wow. Well, it's been a pleasure to be able to share with our larger community some of the work that we're doing, and how we are integral and integrated with providing healthcare and services in our communities and throughout our health system. I would like to say that Providence St. Joseph Health invests in community health investment. We don't make money in our division, so these are dollars that are set aside by policy to allow us the resources to make these investments in community health. So I just feel blessed and fortunate to be part of this type of organization.
Yeah, I'd like to echo that, Dana, and thank you and Martha for the incredible work that you are doing, and just really thank you for joining us today. And to our listeners, to everyone for joining us and sending, just your thoughts and really sharing with us your incredible stories and I think passion for serving our communities. To learn more about our initiatives, programs, and services, and how to support our partner, please visit psjh.give.providence.org. If you're looking for help or medical advice, please visit providence.org. And make sure to follow us on social media under Providence on Twitter and at Providence Health System on LinkedIn, Facebook, and Instagram. Thank you again for joining us and have a blessed day.